issues with computers. And yeah, so I hope everyone's well. Today actually is the first day of summer too. So I think, or at least it's starting. So that's good. I just have a few
Summer solstice. Yeah.
summer solstice. Yeah, exactly. So yeah. So thanks for joining, and I'm just have a few brief introductory remarks. Let me just sorry, I should have started on the first slide. But anyway, yeah. So here we have thanks for joining our Banff Digital Pathology Working Group meeting. And I really appreciate it. And yeah, thanks for joining, Giorgio, and yeah, and yeah, look forward to hearing from you in about a month. So so basically, yeah, thanks for joining, and happy birthday to Kim. I thought I'd put
Thank
that
you.
there. I just happened to see that that it's
Happy
his
birthday.
Happy birthday.
Thank you all. Yeah.
Yeah, and also yes, welcome to the summer. And hope everyone has a nice summer. Yeah, I think everyone's introduced themselves, so we won't go through that today. Sharifa, thanks for joining, and so I think everyone has at least had the opportunity to hear from everyone who's here today. And if you have any ideas for speakers, I think it's gonna be a hot summer. So I know everyone's gonna be really sort of doing a lot, but we're gonna still try to meet every now and then. We won't meet July the 4th, which is a U.S. holiday. Thanks for joining, Dominique. Really appreciate it. And Parmjeet, yeah, Parmjeet, thanks for joining, Parmjeet. Yeah. So I hope people got a chance. I know Kim went to the ATC meeting. Did anyone else have a chance to go to ATC? Well, I'm sure it was great. Were there any
It was.
were there any big takeaways from that?
Well, the evening session, the invitation only future summit was an interesting opportunity, and all the things that weren't there, so like everything important that wasn't there. It's like a major opportunity for people to jump on and make progress on. So yeah, and you don't have to feel sorry that you weren't there at the invitation only summit, because I think it was sort of limited in subject matter. Yeah, that in itself has some interesting consequences. Yeah,
I'm sure Zeno was a big topic at the meeting. Zeno.
Yep.
Yeah.
It was. Yeah.
Artificial intelligence, I guess. Well, that's great. And these were the special speakers, but and so yeah, we won't meet on July the 4th, which is in 2 weeks, but we will meet in a month. And I think Giorgio and Jesper have something planned for that too, to more on their great work. But today I know they're going to have some really special comments. So I think we'll definitely look forward to hearing from them. And everyone put on their calendars the Banff meeting in Paris this fall. I think the abstract submission just passed, unfortunately, but still, if you can go. We will have a part that Thursday. I think both Kim and I have a part on that for speaking on the working group, and Jesper has a part in this session, this digital pathology session. So this should be really exciting. But I think today I'll go ahead and turn it over to Jesper, and then maybe we'll have some discussion at the end, but I don't want to take too much time from Jesper. So thanks so much for presenting.
Yeah, of course. So once again, it's just fully improvised. So let's see. Let me share my screen. So it's going to be not specifically about AI today, but maybe the reason why we want to do AI. At least one of the reasons that I always hear when talking to people is that AI can do it faster. I don't think that's a good business case because we don't see that many cases. Or it can rank cases according to how urgent they are. Well, at least in my practice, that's also not so relevant because I have to see the cases anyway. But something that pops up a lot is, of course, the to solve inter-observer disagreement among pathologists, with the idea that if you have a trained model, every time that you put in the same slide, you get the same answer. That's basically the concept. And of course, we know that for pathologists or any physician, I would say this is not the same, even within one pathologist or one physician. Every time that you put in something else, the answer might be slightly different. So we're talking about inter-observer disagreement. There's some interesting things actually to say about that. So inter-observer disagreement, or dissension, another word for it, or the lack of consensus, it's a problem in renal pathology or in pathology in general. It's often postulated as the reason to do machine learning or deep learning or medical image analysis in general. And the principle is what I said is that a trained model per definition has no dissension. And what I mean with that is that at least in this particular model, there's no dissension. Every time that you put in the same image, you get the same answer. But of course, between models, there is of course also dissension depending on how you train them and with what goal. And these are, let's say, images or tables that you see frequently in the literature. This is for lupus, for instance. You can see that there's a statistic that's being used to calculate disagreement. So they ask multiple pathologists to score basically various lesions in various slides. And then there's some sort of overall level of consensus or dissensus, depending on, these are opposites, of course, with 0 being complete dissensus and 1 being complete consensus. And then always what you hear is, well, we are not doing so well. And you can see that based on this kappa score, interclass correlation coefficient scores. This is for IgA nephropathy, not so much better. This is for transplantation, old paper from 2004, quite interesting paper. They had the same setup, multiple people scoring multiple slides, and they scored for multiple components. And each of these components, you get one metric out, which is a kappa in this case, over all the cases. So if you have 30 cases, 100 cases, 1000 cases, doesn't really matter. You always get one number out, and this is the metric representing the whole cohort. And this paper is quite interesting. I always put it in my slides because it's representative of, I think, the issue is that, okay, they asked this group of pathologists to score. There's some level of disagreement, actually quite some disagreement. And then they had a feedback round, let's say a visual feedback round. So they introduced, well, this is actually what is meant with glomerulitis. This is what we mean with arteriolar hyalinosis. And then they had a new round of scoring, and actually the issue remains. And so that's, as a group, apparently on this particular slide deck, you cannot do better than this. And sometimes they get more confused, and sometimes they remain stable, and sometimes they get a little bit better. But overall, no improvement. So apparently as a group, we do quite poorly. Not as an individual pathologist, because let's say the value of an individual pathologist is also the communication with the clinics. And of course, your clinics at a certain point to get used to your scoring system. So you have some sort of, as a common way of communication. But as a group, we tend to do poorly. And the question is why that is. I mean, we don't know. That might be that so the parameters are too difficult to score. There are too many thresholds. There's always a lot of disagreement around thresholds, of course. I don't think it's because we are bad at our job, to be honest. I hope not. But of course, there's a lot of disagreement on, let's say, the interpretation of the things that we see. So we look at the same thing, but we interpret it in a different way. But what we actually don't know is what does this mean? What does this mean to the patient? It's always said that, well, there's dissension or there's a lack of agreement. Yeah, and then what are we going to do with that information? We know that already. We know that already. Well, for more than 20 years. Apparently, we cannot do better. If you look at the Banff, then the lesion scores are stable over the past 20 years. So, what are we going to do with that? Maybe Kim, what is your idea about that? What should we do?
Well, you know, the thing is that we always think of a world where the only actors are human, right? But at some point, and maybe quite soon, all the big ideas out there, most of them will be, you know, machine generated rather than human. So there will come a time when we humans don't need to decide what to do. Somebody will suggest to us, and this will be a non-human somebody who says, well, look, obviously what you should do is this. And so that will be a point that changes. So there are 2 points to look forward to. One is where we actually find it logical for, you know, a machine to suggest a policy change. And the other is where digital histology can be created from data without any patient. Just saying, well, let's say a typical average patient with these characteristics, what would the kidney biopsy look like? And generate deep fakes in it. So those two things, both of them are coming, but they're just not here yet, right? So the stability, the fact of no change over 20 years, that will not continue forever. That's what I think. Yeah.
Okay. Other people, other thoughts on
Yeah.
what does
Can
this
I
mean to the
speak?
patient, maybe? Yeah,
I
so
have
what?
some thoughts. Can you
Yeah.
guys hear me?
Yeah.
Yes.
Okay, yes. So I think one of the things when people make fun of pathologists is we should push back.
Yeah, for sure.
For example, what is no fibrosis and what is mild fibrosis? They are actually trivial differences. So Banff defines 5% atrophy as abnormal, but it defines 5% interstitial fibrosis as normal, you know? So a lot of this kappa is really things which are clinically insignificant, you know?
Yeah, exactly.
Most pathologists, if you show them a severe lesion, if you show them a mild lesion, there will be no difference. The agreement will be very good.
Yes.
The problem with most of the studies in the literature is that the number of cases which are moderate to severe are a minuscule. They are a very small proportion of the total. So all this kappa really reflects stuff which is not clinically important, you know?
Yeah, exactly.
So that's one thing.
Agree.
Now AI, now supposing you guys in Amsterdam come up with a very good algorithm for measuring IFTA. Well, if Pittsburgh comes up with a similar algorithm, there will be disagreement. The disagreements will continue because they are really the reflection of the opinion of the people who trained them, you know? Now, this doesn't mean that we shouldn't use AI, but it means that when we promote AI, we make them aware of this difference, you know? And one of the problems I have with a lot of AI is they just take one PAS slide, make measurements and say, this is it. This is 99% accurate. Whereas the reason Banff recommends 7 slides and some centers like Boston, they examine 15 slides per case is because we know if we do not look at everything, some error will creep in and substantial error can creep in. Some sections have 0 glomeruli, some have 15. And so whenever we are talking about AI, we should always put that into context, that it has its value, but also has its caveats.
Yeah, at least you have to take some things into account training these algorithms as well. Yeah? I think. Other people that have an idea about what does it mean to the patient if you have a disagreement of a kappa of 0.7, let's say, or 0.6. Does that mean that we're mistreating the patient, or any ideas about that? Because of course the things that we say have consequences.
Yeah, so I think an experienced clinician, if we tell him the fibrosis is 60%, he should interpret it as meaning that is between, let's say, 40 and 80%.
Yeah.
And in another case, when we say the fibrosis is 20%, he should interpret it as anything from 10 to 30%. So once you have that nuanced interpretation, I don't think it changes management. It's just a way of communicating. We are trying our best, and the user has to recognize the inherent error. So as long as that is done and it's put into the context of a clinical picture, these numbers should not, no fixed threshold should determine treatment. Yeah.
So maybe we should not put too much on it. Maybe it's
Well,
not
we just
so
have to teach the
completely
clinician.
right.
When we give
Yeah.
you numbers, they are estimates. They can be
Yes.
useful, but they will always remember their confidence interval. Yeah.
You have a level of uncertainty.
Yeah.
Yeah.
And AI is not going to change that because you're just creating a tool which one group of pathologists created. Another
Yeah,
group
for
will create
sure.
a different one. Yeah.
For sure. Okay, so the consequence of these disagreement scores, I think we don't know. That's
Well, they are not measured.
they're not measured. We don't, and
No,
therefore we
not
don't know.
measured. They are not major consequences.
Major. Yeah, that we don't know, of course, also, because it depends on the communication, I guess.
Oh, yeah. But
Yeah.
with proper communication, there shouldn't be really any malpractice resulting from these
No, I don't think so either.
variations.
Yeah. So definitely there's a disconnect between the type of studies that you see and the metrics being reported and the actual clinical practice. Yeah, so, yeah. Okay, so what do these kappa statistics actually reflect if you are critical? So they also reflect case label distribution. So if you have exactly what you say, Parmjit, is that if you have only one case with a CICT score of 3, yeah, that's probably going to be a different kappa than when you have 80% of CICT score of 3. And so the distribution of your labels in your cohort, looking at it from a technical metric perspective, it really matters what type of cases what your case mix is, of course. So kappa statistics is completely irrelevant, I think, because it's a reflection of your cohort. Also, if there are more difficult cases, your kappa goes down. I think that's so. There's of course no comparison between cohorts. So if we're talking about this kappa, the only thing that is being reported in the literature when people make fun of the pathologist is that they say it's poor. That's the only thing that's being reported. The other problem is that if you talk about kappa specifically, the way that the chance agreement is calculated is not correct. And so there are some other alternatives, like here this GWET measurement, it calculates a different way the chance agreement. And of course, if you have a prior chance agreement at agreeing or disagreeing, then if you are very close to that chance agreement, your added value is not so much. Also, there's one metric for the whole cohort. So it doesn't matter if you investigate 1,000 cases. And of course, some of these cases are more difficult and some of these cases are easy. So you should actually look at the distribution of your inter-observer agreement across all your cases. So there are some heights in the literature, I would say. So in Amsterdam, we had 3 research questions basically. What is actually the prognostic effect of dissension on the per biopsy level? So we have to calculate disagreement in a different way. And is this effect independent or dependent on the activity that you see in the biopsy or the chronicity that you see in the biopsy? You can imagine that your dissension goes up when there's more activity and chronicity. So it might actually be a reflection of that. And can we actually identify and predict the degree of dissension directly from the whole slide image? So can we see from the whole slide image if this is a case where people tend to disagree on? So can you actually use it as a measure of uncertainty? Exactly what you just said, Parmjit. So maybe it's nice that you say the receiver, they should know that if you say 20%, it should be between 10 and 30%. But maybe, let's say, identifying the level of uncertainty based on a group level might be an interesting metric to report. That would be my opinion. Okay. So we have in Amsterdam set up this deep graph cohort. Of course, with the idea to do deep learning on grafts, transplants, on kidney transplants. We had a big set of more than 1,000 cases, for which we had an H&E, a pus, and a silver stain. It's really a lot of work, also for my colleagues. They were Banff scored for all the lesions in retrospect by 3 nephropathologists for more than 1,000 cases. So it's really, really a pile of work. Took 2 years to do, but yeah, really a nice, let's say, gold mine of data to really mine all these concepts that I've just been talking about. We also extracted clinical data for later on. We can match all the imaging data and the dissection data also to clinical data points. We had extracted actually 4 million clinical data points of these 1,000 patients. 300 cases, we also performed proteomics on FFPE tissue with data independent acquisitions. For now, not relevant, but for later on, we'll do something with that. And so what I said, we all had these cases digitized, H&E, pus, and silver at high resolution. And then we also had a test set from Utrecht, different city in Holland, with more than 800 cases for which we had clinical data and also this set of whole slide images. Of course, not, let's say, 3 pathologists score everything. And so this is really a test set for all sorts of predictive things. And if you want more details, you can look it up in the paper that we published 2 years ago. So huge pile of work. Now, the next thing that we wanted to do is search for a metric that can is actually able to represent consensus or dissension on the per case level. Because we don't want one metric for the whole cohort. We'll also calculate that, of course. But if you want to do prognostication, you really want to have one measure for each case. And this is actually, there's almost no literature if you start looking into it. In the medical literature, I could not find anything. But there's an interesting paper from the social sciences, or actually information theory. And they have this measure of consensus that is actually used for Likert scales. So these Likert scales are used in questionnaires. If you do you strongly agree, somewhat agree, undecided, somewhat disagree, or strongly disagree. This is an ordinal scale, and the difference between strongly agree and somewhat agree is, of course, it's not a measurable difference. So it's very similar to the ordinal scores that we give to biopsies. There's some level of difference, but it's not a quantifiable difference. So this seems to be quite interesting. There are different ways of writing exactly the same, and I think so this is more in the direction of our ordinal scores, but conceptually, this was something that I was interested in, so I went deeper into this paper, and they present a new measure for to calculate consensus based on entropy. And entropy is a measure from information theory that captures let's say the level of surprise in a system, how much information is in a system. And they basically say that when there's a high degree of entropy, it means that there's complete deviation between opinions. And when there's a low degree of entropy, it means that there's a lot of, let's say, aggregation of information into one of these categories. And these are these ordinal categories. So they developed a consensus measure that should reflect that based on this entropy. So it's one measure for one, let's say, in this same question or case, in this case, that represents the level of disagreement. And that's something that we wanted to validate. You can see here it's independent of the number of cases. If you have 5 that strongly disagree and 5 that strongly agree, your consensus is 0 because it's completely spread out. 50 versus 50, consensus still 0, etc., etc. And if you have 51 versus 49, there's a little bit of consensus, but it's minimal. So it really reflects the level of disagreement. And here they say exactly the same, exactly the opposite. Let's say you start off with a completely divided opinion. 5 say strongly disagree, 5 say agree. And then you move a little bit towards, let's say, strongly disagree. Then you see also the level of consensus going up. So it seems to reflect let's say the path towards consensus also in a good way. Quite interesting. So this is what we actually calculated. And now comes the not so pretty part, because I have to cut them all from my notebooks, the presentation, because it shut down this morning. What you can see here is all these Banff scores, and for every Banff score, for every case we calculated the level of dissension for each of the individual cases. And of course, if you take the average of that, you can compare it to the classical statistics, because the average, let's say, it's the same as having one measurement over the complete cohort. So that's what you can see here, and we'll go into the individual cases after this. So here you can see this GWET score, or the Fleiss kappa. You can see it for all the different Banff scores. This is this dissension score, and you can see actually nicely that if your GWET score goes up, then your median dissension goes down, and this is exactly what you expect. And so this is, and it's actually a very, very strong correlation. So it means that if you take the average of all these measurements over the complete cohort, it's almost a perfect reflection of calculating the GWET over the whole cohort. Okay, so far so good. So we could actually validate that let's say the classical metrics that we use for calculating dissension actually align with taking the average over all the cases. And the nice thing is that this chance agreement, of course, in the individual case does not play a role, because you calculate it on the individual case. So you don't have to correct for chance agreement over the whole cohort, which is pretty nice. So it's very nice that it aligns, in my opinion. And the nice thing about that is that you don't get one measurement, but you get actually a distribution of measurements. Every case is one single measurement. And you can say, for instance, okay, well, if you disagree on tubulitis and disagree on interstitial inflammation and disagree on peritubular capillaritis, yeah, the biopsy becomes more and more difficult. Apparently, you disagree across multiple lesions. Of course, the biopsy is more difficult. So here you can see actually the difference between active and chronic lesions. This is the level of, it has to be dissensions, not consensus. There's more dissension on active lesions than on chronic lesions. So we do better on chronic lesions than on active lesions. The same for, if you look at, let's say, the different compartments, glomeruli, so glomerular parameters, Banff lesion scores, we actually tend to agree more on than on the tubular interstitial scores. Quite interesting. So these are things that these are hard to measure when you're talking about, let's say, the overall cohort statistics.
Mm-hmm.
So you can also calculate in biopsies that have, for instance, 1 to 5 glomeruli, what's the level of dissension, and you can really see that it's relatively stable. Only when you have not so many glomeruli, your level of dissension goes up, probably because it's difficult to calculate what is 50% of glomerulitis in only 3 glomeruli. And so these are, let's say, I think everybody who scored slides, they can maybe imagine that sometimes it's difficult when you don't have a lot of cortex. And it's also becoming a little bit more difficult when you have too many glomeruli. There's an overwhelming amount of things that you can look at. The difference is not so big, but you can see a little bit of a U here. Also, when you look at the percentage of sclerosed glomeruli, then you see when there's more glomerular sclerosis, your level of dissension goes up. This is different pathologies based on the report. So this is the report diagnosed in a period between 2000 and 2019, I think. Thinking, of course, about the fact that every 2 years the Banff classification changes. These are the outcomes of multidisciplinary meetings. So this is really the report based on multiple pathologists and multiple nephrologists going into a room. And this is how we report it. And you can see that if you have protocol biopsies that are from stable patients without too much pathology, your level of dissension is very low. Actually, that's across everything, if there's not so much to see, we tend to agree quite well. Let me see, for instance, here, T-cell mediated rejection, it goes up. The one that is highest is, if I see correctly, number 3, mixed rejection, this one. So you can see it, the level of dissension depends a bit on the diagnosis that we're looking at. And because we have these measurements at the individual biopsy level, we can actually check if the prognosis of that biopsy was good, and we can calculate these Kaplan-Meier curves and Cox regression models, etc. This is the time of biopsy, is time point 0, and then this is the follow-up time. In red, you see the cases where the level of dissension for the G-score is 0. So this is complete consensus. And blue, the level of when there's some degree of dissension between these 3 pathologists. And of course, these patients were not treated according to this new metric that we have here. So we did not know the level of dissension at that moment. So I think it's quite striking that you see such a difference if you only look at the dissension for glomerulitis, for instance. But you see it across all the scores that we have. At the moment that you start to disagree, every time it's red is 0 dissension and blue is some degree of dissension. It's actually quite a good biomarker. If you look at transplant glomerulopathy, for instance, quite a big change. IFTA, not so much. This is the ordinal score for IFTA. But across the whole, let's say across all the Banff lesion scores, you see the same pattern. Those cases where there's complete consensus, they always did better than those that did not. Okay, what you can then do is create a multivariable regression models where the input, the independent variables, are all the levels of dissension, and the thing you want to predict is outcome. So these are the hazard ratios, and you can see that if you weigh them all in one model, some things are more important than other things. You can actually create a score from this, a multivariate score, taking into account the beta coefficient of this multivariable Cox model. And then you can have a look in the, let's say, the overall biopsy consensus or dissension. So this is what you see here is a combination, is actually the prediction model across all the levels of dissension, with the idea that if you disagree on multiple parameters, the level of uncertainty in your biopsy really goes down. And that's actually what you see. So here you see the first quartile, second quartile, third quartile, and fourth quartile. You can really appreciate the difference between the first quartile, so high level of consensus, and here the fourth quartile, high level of dissensus or dissension. And this is actually a score that is quite interesting because we can do something further with that. Well, I showed you that, of course, it's dependent on what type of diagnosis you have. And so some diagnoses, and for instance, if you compare protocol biopsies with a mixed rejection, of course, you expect that the mixed rejection has more dissension. So are we not just measuring the fact that this is a different diagnosis? Or better said, is it not a reflection of how much activity and chronicity you have in your biopsy? So group of Maarten Naessens in Leuven, they developed this reject class algorithms. There are 2 algorithms, one for the acute lesions and one for the chronic lesions. And they should reflect the activity and chronicity index of the biopsy. This is, we applied that to this cohort of 1,000 patients, and you nicely see that indeed both the acute parameters as well as the chronic parameters, they predict prognosis of these biopsies. And then comes the interesting part. If you take a model, multivariable model, where you include the acute reject class parameter, you include the chronic reject class parameter, this weighted dissension, what I just showed you, this multivariable model, plus the interaction between those, because you can imagine that And what I just said, that if you have more activity, then your dissension also goes up. So you really have to look at the interaction in this model as well. You can see that the dissension is actually still a strong prognosticator in this case, independent of the acute lesions, the chronic lesions, and the interaction of those. And actually, the model fit is a lot better when you look at this model versus that model. So it seems to have prognostic value. So some conclusions so far. Dissension seems to be a strong prognosticator, and maybe we should use it as a weighing factor for uncertainty. Actually, we checked also the if you have, let's say, the weights of the iBox paper, you see exactly the same phenomenon. So if you take the predictions, the biopsy predictions of iBox, and you add to that dissension scores, the fit of the model is going to improve. So it seems to be some sort of weighing factor that can leverage out the differences between the pathologists. And it seems to be independent of the activity and the chronicity index or indices. And it works actually in most diagnostic settings. So if you only take patients that are rejecting, you still see the same pattern. If you take patients that have pyelonephritis, you still see the same pattern. Within that group, dissension predicts prognosis. We also did a lot of sensitivity analysis for clinical settings, patients with delayed graft function across all HLA, let's say mismatches. You still see that this dissension actually associates with outcome. Okay, so what about prediction? So one of the interesting things that we are trying now is, what if you just have a whole slide image? You don't want to be dependent on the pathologist. You just want to know, is this a difficult biopsy, yes or no? Maybe if you want to prioritize in some way, or maybe you just want to communicate that to the clinician, this is a difficult biopsy. So why not make a prediction model where the input is a whole slide image that we cut into pieces? We use a histology foundation model to extract features. We use a new model that Giorgio will introduce in more detail in a month, to aggregate the information from these features, and then we actually create a regression analysis on top of this, predicting the level of dissension. So it's a whole slide image model predicting dissension. For this, we used a foundation model, and this is something that we will discuss, I think, also in the Banff a bit in more detail. In the past 2 years or so, there have been multiple foundation models being proposed, most of them actually private, some of them are public. Bigger companies are now working on creating these foundation models, training them on huge amounts of data, huge amounts of histology. A lot of that is actually oncology. That's good to know. I think the paper from Boston, the group of Mammoet, is very nice. They produced this model called UNI, or Uni, I don't know how to pronounce it, but it's a very nice model. This is actually the case distribution, and they make that available for academic use. So we actually use this model to make the predictions, to extract the features and train the model on. And then we applied the predictions of that model to that data set from Utrecht. And you actually see exactly the same phenomenon. This is done on silver staining, and you can again divide them in quartiles, and you actually see exactly the same distribution. So this is input whole slide image, in this case a silver staining, and the output is the level of dissension that again predicts in this test set the level of the time to dead censored graft failure. Here you can see the hazard ratio. The nice thing about this model is actually it's a probabilistic model. You can go back into the model and check which patches were most relevant probabilistically and actually sample those. And Giorgio will go into detail in a month, because you can actually also highlight those regions that are important in those images. But you can nicely appreciate, let's say, what are the most predictive patches in these silver stainings that predict whether a group of pathologists is going to disagree on scoring, which I think conceptually is very interesting. a lot of edema, a lot of let's say it's a bit in between atrophy. There's a lot of inflammation dispersed through this edema. It's something. I will go back in. I will get into that a little bit, but this is a pattern that we see more often related to dissension. We will go definitely in more detail because there's still some ongoing work. Something that we want to check, for instance, what are the molecular determinants of dissension? Can we actually, is there some molecular changes that we can use to predict the level of dissension? We want to train models for each of the Banff parameters to trace, for instance, if you have a high dissension for glomeruli, is the signal why people disagree on those glomeruli, is that actually in the glomeruli? And it might be that, you can imagine if you're scoring peritubular capillaritis, that it might be actually the interstitial infiltrate that's messing it up for all the pathologists. So those are things that we can actually try to answer. We can visualize that both on the slide level as well as on the patch level, based on these probabilities. We want to validate in more data sets. We have a couple that are actually ready that we still have to run. We're also trying actually a prediction model that is not based on a whole slide image, although I think that's the best way of looking at it, but also on the local pathologist scoring for Banff. So that's basically how that looks, is that you have your own Banff scoring system. You have your own system, your own way of scoring. And with those scores, you can actually predict the level of dissension as well. That's something that's a little bit more difficult because you have, of course, there's the level of disagreement is captured in that data set. So we have to titrate a little bit better, but it seems to work also, independent of which pathologist scores, which is good. And we have now this international reader study that we will use also to validate this work, especially aligning the level of dissension that is calculated or predicted by this model to the international reader study. And that international reader study now is ongoing. We have people from 29 countries, 106 users, if you exclude my double account in this. We're actually representing around 700 million people in terms of practice, which is really, really interesting. I think it's one of the biggest inter-observer studies that are out there, and we can only do this because we can do it digital. I think if you have to send around all the slides, it's going to be super impossible. So I think that it's already nice to describe this process and the data set. So definitely everybody involved, will have multiple papers coming out of this. And in terms of practice, in terms of the countries that are practicing, 46% of the countries in terms of population are represented in the study, which is really nice. So not all regions are represented. We definitely, US and Europe are the most represented, but we have many different countries also in Asia, some in Africa, South America. So that's really nice. So hopefully we'll get some data out there soon. And that's it, what I had. It's a little bit of a teaser
Very
in
cool.
1 month. In 1 month we'll go into more detail.
So, what I particularly like about this, if you think of things that will naturally happen in the future, medical jargon will go down without doing anything, because you don't need any human action. Any person out there who says, cell phone, convert this text into something I can understand, and it'll convert medical jargon. And so the things about this that are really appealing is your use of words like surprise and, entropy. These are words that go way beyond medicine, and yet they will bring people in and create links of understanding because of the absence of the jargon barrier. There's a literature about jargon. There are grants, funding, information about jargon, but that's likely to be completely excluded. Jargon will be removed so quickly in terms of human interaction that they won't cite any of the literature or anything. They'll just do it. And people like you using these general words entropy, surprise, that's going to reach a lot of people that if we strictly stick to medical terms, we couldn't reach.
Yeah, I hope so. I hope it doesn't confuse people more. We'll see. We'll see what the editors will think.
Oh, that's a very nice talk, Jesper. Thank you. So the
Thanks.
question I have for you is just give me an update where the AI measurement of glomerulitis and peritubular capillaritis stands, because I know after talking to people in the kidney precision medicine project, you guys are not doing very well in IFTA, because that's a very difficult thing for the pathologists.
Yeah, we'll talk about that in a month. It's not actually we submitted to the Banff an abstract because we trained actually this model on all the Banff parameters, and it performs very well. And the internal structure of, let's say, the cross correlation between parameters that you actually see also when people are scoring the Banff, for instance, the correlation between a G score and a PTC score is completely preserved across multiple data sets that are independent, other scanners and stuff like that. So we now have the idea that we actually grasp the, let's say, the essence of the slide, and based on that we can actually do meaningful predictions. So it is coming. It's still ongoing work, and we're trying to validate that also molecularly and also with retrieval. So a bit of sort of a Google reverse image search versus the pathologist, and it seems to actually outperform what the pathologist can do. So it's really, really interesting because these are scores that are continuous scores, probabilistically on a slide level as well as on the patch level, that we can trace with attention. So we'll talk about that in a month. I'm very enthusiastic about what we created, and especially what Giorgio has made. And yeah, we submitted to the Banff for the Banff meeting as an abstract.
No, I look forward to that. But very quickly, you need immunoperoxidase like CD34, CD45, or HNE or PS is enough?
No, so you can do. So the nice thing is it's a multimodal model, so you can do it on H&E, PAS, silver. You can on any of the stainings. Of course, let's say PAS and silver I think work better. And one of the things that I'm thinking about is that we, for instance, people can send their slides and we calculate for them probabilistically all these Banff scores that are continuous, and then people can work with that, for instance, and correlate it to all their favorite molecular data and things like that. That's maybe a bit of as a service, let's say.
Thank you.
Yeah, or an online module, but I mean, it's always there's still quite some handwork in applying these AI models with the with the extraction and things like that.
All right, thanks.
Yeah.
That was an outstanding thought. Thank you so much. That was really awesome, and it was thought provoking too. And I was wondering, I've tried to bring up with the groups I've worked with, about when you report scores, it's also, and you kind of touched on this too, is a function of the sample. So like a small sample, basically, if you put a confidence interval on that, it's going to be pretty broad because the sample is small, you're not as sure. Whereas a larger sample, you can have a smaller confidence interval because it's more representative. Have you seen anyone trying to work, or have you worked that into your work here some?
Like a confidence band for the uncertainty, or?
Yeah, sort of like, so the I mean, it might say something like, okay, interstitial fibrosis plus, as Parmjit was saying, it's all a range, you know what I mean? But that range, I think, gets smaller as the
so that's a bit what I had in mind. So we can calculate them on the individual, so the level of dissension on the individual lesion level. For instance, that you would say, okay, I say it's maybe it's IFTA 20%, but the level of uncertainty, the level of dissension is 80%. So I'm really not certain about it. And I think that is how I think about how we already communicate findings to our clinicians. And of course, in reports, that's sometimes a bit difficult, and that's why sometimes things are a little bit lost in translation when you only communicate through reports. So it might help with the communication if we tunnel it well, I think. So you have to see it a little bit in that range. So it's not that you can say, well, based on this level of uncertainty, let's say the confidence interval is between 10 and 50% IFTA or something like that. No, it says the level of uncertainty. What if you ask a group of pathologists, how certain would they be? And that's I think this is it's very aligned with how we do our job. If you don't know, you ask a colleague, what do you think, right? So it's and preferably for every case you ask 10 colleagues, but we don't have time and resources for that. So I think it is interesting to say something about that on the case level. And so how difficult is this case in general, or actually specify it for each of the individual parameters? That might be, yeah, it might be useful information to report, but yeah, we have to work that out further, I think, because if you want to have that adopted, of course, it takes takes some time and also some willingness from the clinical colleagues.
Well, that's awesome. Yeah, I mean, yeah, this is so deep and thought-provoking. I'm going to have to process it some. So does anyone have any questions or comments?
Well, I really looking forward to the presentation 1 month from today.
No pressure,
That'll be
Georgia.
great. Yeah.
No, it will be. It's very nice. I'll promise.
Yeah.
So there's another interesting phenomenon that we've found out on this consensus work. Is that there are some lesions that are structurally more difficult. It's like it's inheritedly more difficult. And if you look at what those lesions are, it's IFTA, T-IFTA, PTC. Those lesions that require multiple thresholds to score. You first have to know if there's PTCitis, then you have to judge if it's more than 10% or not, and then you can score. So these are multi-threshold scores are difficult. IFTA the same. Is there, let's say, is this 10%, and what is the density of cells in that 10% of IFTA? It's multi-threshold. And the interesting thing is that so we calculated this on the head. So what I just showed you, 1,000 patients, and we had 3 pathologists. And now we have this reader study, different hospital, different type of slides, different pathologist scoring, exactly the same parameters come out. Difficult. Actually, there's a very, very strong correlation between the level of dissension between both independent cohorts. Independent pathologist, independent slide. So this is really a preserved pattern. Some things are just inherently more difficult. And that is something that we have to take into account, a bit like the IgA nephropathy working group. So they say, well, if you have a parameter that you cannot score because you have such a high level of dissension, maybe we should not use it for a classification. We can score it, but maybe you should not use it to base your decision on. So that's, yeah, I think for IFTA, it's really should be part of the discussion, I think. It's really falling out. That's one.
Yeah.
Yeah.
Interesting.
Yeah, it's very
Okay,
interesting.
cool.
Yeah.
Well, thank you very, very much. And we'll see you in a month.
Yeah. Thank you so much. That was awesome. Thank you all. Have a good month and good summer. Take care. See you in a month.
Bye-bye.
Bye.
You. Bye.